of cases, and then at the end of like each subsection we'll have a discussion for the points learned.
But intermittently, if questions will come, I will throw the questions, huh? So
Absolutely.
because the audience remain connected. That is the
absolutely
issue.
Absolutely, that's the whole idea. The audience should find it interactive.
Yes, Abhi is there.
Yeah, Abhi is now there.
Yes, good. Connecting with audio.
Yes, yes.
Keમ chho, Dr. Sir?
Yeah, all well.
Abhi, welcome.
Yeah, thank you to all.
Yes, in the background there is probably some noise is coming. So Abhi, can you?
I'll use the other room. Yeah.
Yeah.
સાહેબ હવે પાછા નેટ ના લોચા પડશે રૂમમાં.
ના, it won't happen.
Okay. કારણ કે મારા એ રિયલ એસ્ટેટ
डायरेक्टर की रूम में चले जाओ.
नहीं, हमारा see the main reason is अभी काम नहीं है तो सब लोग इकट्ठे होते हैं ना.
हाँ, बातें करने के लिए क्या करना है, स्ट्रेटेजी बना रहे हैं.
कोविड हॉस्पिटल बना दो तो पूरा बिजी हो जाएंगे.
बाकी सब बंद कर दो, कोविड हॉस्पिटल.
बाकी सब बंद कर दो.
अपोलो कोविड हॉस्पिटल.
That's right, yeah.
Okay. So.
Okay.
Now I think everybody has joined.
Yes.
So I am starting the introduction. I am just starting the sharing the screen now.
16 January 1957. 01.
I'll be giving a short intro. Right. Welcome to all the faculty. We welcome on behalf of the Gujarat Orthopedic Association, and we are very much thankful to Dr. Dhiren and Dr. Praveen for collecting the cases and getting it moderated in a one module very well in a sequence. And for the delegates, the page you are seeing here of the link 34, here is the recording link where you can go for the recordings of the previous webinars and you can see the previous webinars. As you go down, there is an arrow here. Just click this arrow and you will see the luminaries of these all faculties, and we'll present you the subject of patient safety, right? And there is a small announcement. Dr. Dhiren Ganjwala is also arranging on the 1st May, again same time, Geo webinar on doctors and patient safety in COVID pandemic, because we are getting so many queries, so many feedbacks from the delegates. How should I start my practice when this lockdown is opening up? So we'll be having this webinar on 1st May, that is decided, and all the material is getting collected, all faculties are consulted. As you go down, delegates, there is a Slido window to ask the question. Here you can type your question. I have put a 160 character limit to have a crisp, short, right question. So just click send button here and it will come to me. Those who cannot write or they have problem with the mobile they are writing, they can record the audio or a video in a WhatsApp and just click this link of WhatsApp to Dr. Navin. It will come to me and I will give it to the moderator and the faculties. Let me introduce in short faculties. Dr. Praveen Sarda. He was working at the UK and he will be leading us as a moderator with the help of Dr. Dhiren Ganjwala as the moderator. Dr. Prakash Amin, Senior Orthopedic Surgeon at Ahmedabad. Dr. Matthew Varghese, everybody knows him at St. Stephen Hospital, Delhi. Dr. Subir Javeri, he is having 4th encounter of the Geo webinar. He has moderated 3 spine webinars very successfully. And Dr. Nityanand Rao from Mysore is the past president of Karnataka Orthopedic Association and vice president of Oasis just now. Dr. Navin Thakkar, very dynamic orthopedic surgeon from Rajkot. He was the organizing secretary of the last GoaCon in Rajkot. Dr. Anand Joshi is joining from the Raipur. There is a thunderbolt, is there in the Raipur, and he's trying to connect with the internet. Dr. Prahlad Singhi is from Madurai. Dr. Abhijit Seth is the DNB chairman. He is with us. He is the director of the Apollo Ahmedabad. Dr. Lalit Maini, everybody knows him. He is the editor of IGO. And myself will be just connecting between the audience and you whenever it is required. So now, Dr. Praveen, you can take over. I am stopping sharing.
Okay, thank you. Good afternoon, everyone.
Good afternoon.
Good afternoon.
Right.
afternoon.
Thank you so much for giving your precious time and effort in this webinar that we've compiled together to enhance patient safety. And our faculty, our panelists are all going to discuss some of the cases that they've come across during their years of practice and what they've learned from those cases. And I hope that from their experience, our delegates who are listening in will be able to improve their practice going forward. So Navin Bhai has kindly introduced the faculty. And it said that an average person learns from own mistake, which is the human nature. That's how humans have evolved, by learning from their mistakes. But an intelligent person is one who learns from others' mistakes. So here we are trying to learn from others' mistakes and improve our and our patients' lives. The concept, Dhiren Bhai has been very kind in spending a lot of time and effort to compose this module. And this is actually a small slice of a full day program that we run on behalf of the Patient Safety Foundation. And we have a course called Look Within, where we discuss these adverse events and also the psychology behind these adverse events and how to prevent them. Today, if the time permits, we will have a brief insight into a little bit of that module. But if not, we'll be just discussing the case details and the learnings from it. Navin Bhai has already introduced all the panelists, so I'll skip that and I'll hand over to Dhiren Bhai for the next section.
Yes, good afternoon, everyone. We all are aware that the airline industry is very well known for its safety feature. And whenever we are talking about the safety, we always try to look at the airline industry. So let's take it example. Next slide, please. Suppose under the leadership of Navin, Gujarat Orthopedic Association flourishes a lot. And then we decided to have our own Gujarat Orthopedic Association Airlines. And if you are a passenger in that case, I am going to give you a scenario. So just listen to the introduction. When you are in the plane, you have already fastened your seatbelt and there is an announcement. And the announcement is something like, ladies and gentlemen, this is your captain speaking. We welcome you to the Gujarat Orthopedic Association Airlines flight number 123 going to Mumbai. Our flight time will be 1 hour. However, it's our duty to inform you that in that 1 hour, you have about 4% chances of having an accident. Let's take it positively. There are 96% chances that you will reach your destination without significant injury during the flight. It is also our duty to inform you that every year, about 4 lakhs passengers, they die during the air travel. But don't worry, we will take your utmost care. So now relax and fasten your seatbelt and enjoy the flight. So now the question is, I am going to ask all panelists one by one, like if you are on the board of such flight, whether you will continue or whether you will get down. So I will start with Prakash Amin first. Just tell me whether you will be on the board or you will get down.
I will certainly be on the board looking at the past history of the airlines. But see, this is a journey which we have to take. And during this journey, the risks are bound to be there. And if those risks are reasonable, then you will definitely undertake that.
Okay, we go to the Subir. Will you be on the board?
Right. So yes, I will continue to be on board. Only thing is that there is always this risk-benefit ratio that needs to be thought about. what Prakash bhai just said. And the thing is that despite knowing that all these things do happen, we are not going to stop flying. And in that scenario, I'll definitely be on board. And only thing is that once these announcements keep on happening day in and day out on each and every flight, then there is something like a desensitization that happens. So if we are going to talk about this scenario in terms of the whether we talk it out with our patients or not.
Subir, please just answer the question by yes or no, whether you will be on the board or not.
Yes, I
yes,
will be.
Ketan bhai, yes or no?
I'll definitely be on board.
Okay, Nityanand, whether you will be on the board or you will get down from the flight.
With Dhiren and Dr. Navin, 100% I'll be on board.
Okay, this is Gujarat Orthopedic Association Airlines. Okay, what about Prahlad?
Sir, definitely I'll be on the board.
Okay, Dr. Lalit?
I'm going to be very frightened, and I'll ask them, do I have an option of getting off the plane? Because if I'm listening to this first time, I'm very frightened.
Okay, and Abhijat, like you are the captain of the ship, or like you are the passenger, what will be your decision? Abhijat? Okay, fine. So most of us say that we will be on the flight and we will not get down, except Lalit said that I will be frightened. And what Subir said is absolutely right. Like with each such announcement, we gradually become desensitized and we lose the importance or the fright of the such announcement. And that is what actually the scenario is. Next slide. First of all, let me tell you what is adverse event. We are going to discuss that, but so let us understand the definition of that. An unintended or unexpected incident which could have or actually cause harm to the patient. So that's the adverse incident. We all are familiar about that. Next slide. A wonderful study was carried out by an association which is National Academy of Medicine in the year 2000, and they surveyed, and from that survey they came out with the statistics that they say that 3.7% of the all hospital admission they have adverse incident. Next slide. And that results into almost 1 lakh death per year in USA. So coming to Indian data, Praveen and I tried to search for the Indian data about like the adverse incident, but unfortunately when we tried to search, next slide, it was completely blank. We could not find any data, any paper which tells us about the adverse incident ratio in our country. Next. So we try to approximately find out US population and our population is 4 times that of US population. So if we try to approximate the statistics of USA, approximately we see 4 lakhs death per year in our country. This is approximation. So now the next question to every faculty, what do you think about the number? Will it be more, less, or same? Let's start with Dr. Matthew first. Matthew, what do you think? You have a vast experience at teaching hospital. So what do you think? The number will be more, less, or same?
I think the number should be more.
More. Okay. Lalit, what do you think?
Should be same.
Same, almost 4 lakhs per year. Yeah, Prahlad.
It will more or less, it should be same, sir.
Same, right. Ketan bhai, what do you think?
I also believe that it should be same, of course, with a few small changes here and there.
Right, so more or less all of us agree that the rate of death, this is about the death, 4 lakhs death per year is because of the adverse incident which take place during the treatment. Next slide. So now I am going to ask you one simple question. Is there anyone in the panel who has not seen adverse event? Anyone, if there is someone who has not seen adverse event, please say yes. Yes, so everyone has seen the adverse event, and that's why like you are on the panel. Next slide. One of my professor used to say that, Dhiren, don't worry about adverse event. Only outstanding surgeon does not have complication. So I was always like trying to understand that what he's trying to say about outstanding. Then one day he explained me by outstanding means the surgeon who is standing always outside the operation theater, he will not have complication. Rest of the person or rest of the surgeon will have complication. So I'm sure that none of us are outstanding in that way. So I now hand over to Praveen for continuing the session.
Thank you very much, Dhiren bhai. And that's a very important point, that throughout the course of our careers, we will always have some degree of complications. But the question is whether the complication was avoidable or unavoidable. And I think what we are trying to do and trying to achieve by during this talk today is to find some common factors that can mitigate against the avoidable complications. And there's been various studies. I'll quote a couple of those studies later on during the talk, that at least 50 of the complications or 50% of the adverse events are avoidable, provided we follow certain basic protocols. So let's talk about the ill effects of surgery. So if I can start with Amin Saib again. So in terms of the ill effects, some complication has happened, sir. What kind of effects have you seen on patients as well as doctors? Amin Saib?
Hello, Amin
Hello.
sir. I think we lost the connection with him.
Okay, let's go to Dr.
Now he has,
Am I audible now?
Yeah, you're audible, but your voice is cutting.
Okay.
But anyway, we will understand. Go ahead, sir.
That is the problem for last 2 days.
Yeah,
Right. Yes, any type of adverse event is going to, the first thing is, it is going to cause a lot of anxiety in the mind of the patient and relatives, and a lot of stress to the surgeons. If the surgeon is a good amount of conscious, then I think yes, he will have a lot of stress.
Right. Thank you, sir. Dr. Prahlad.
Sir, like everyone can have an adverse event during their practice, but it is important we sensitize the patient by taking appropriate, so whatever the kind of complications we anticipate. So we can just give a brief idea about the consequences which can happen, so that we sensitize the patient that these are things which can happen, so they are a bit prepared for these kind of things.
Thank you. Thank you. Dr. Mani, can I have your insight on this, please?
Definitely, the patient is going to face the morbidity and mortality, and the surgeon is going to face the stress of the facts with the patient and prognosticating him what is going to be the ultimate effect of this problem.
Thank you. Thank you. Ketan,
I first of all believe that the most important ill effect that a patient or his relative would go through is, of course, mortality, because that is something which cannot be reversed. There are other things, I mean, the morbidity and all that is a very relative terminology, but obviously a lot of things, the major thing that we really need to understand is the fear or the genuineness of a second or multiple surgeries which can come across to a patient. That is the basic problem or the basic ill effect that a patient will suffer, because for them one surgery in itself is a big event. So getting to multiple surgeries is a big problem with them. Getting on with some permanent disability or a deformity is also a major ill effect which the patient will have to sustain with. From the surgeon's point of view, I believe the important ill effect is the kind of stress, or how will he answer, what will he answer, and the future liabilities that can happen upon him are, I guess, the most important ill effects that one can encounter.
thank you so much. So yeah, I think, throughout the discussion, we've summarized most of the ill effects. So there are various gradations of the adverse events, some of which will not have any adverse effects, luckily. Some may result in more discomfort, some may result in delayed recovery, prolonged hospitalization, cost issues, or unfortunately, in some cases, complications can result in death. From the doctor's side, the effects start from, sometimes there can be arguments. Unfortunately, it's all too common to have some physical abuse, especially in India. There is obviously the issues of financial loss, some medical legal issues, image issues. Obviously, our profession is based on trust, and these things can spoil the image of the doctor. And in severe cases, loss of the practicing license, and obviously the mental suffering that goes with all of that. So as I said before, there are various severities of adverse incidents. So mild one is like there is no intervention is required. So why is it an incident then? So for example, you have two patients in a clinic sitting outside with similar sounding or same name but different surname, and the patient who gets called to your chamber, you have the other person's file in your hand. Now it's a very innocuous event which in itself will not cause any problems, but potentially if then we go on prescribe some wrong medication to the incorrect patient, it can have repercussions. So that way it's mild to begin with, but it can progressively become worse. Moderate incident is when there is no need for some non-invasive intervention, and severe incidents. Hello, I don't know whose mobile it is. So severe incidents is when
Please close
hospitalization.
your mobile rings, please.
So if the patient requires hospitalization or prolongation of hospitalization, that is the severe incident. Then grade 4 incidents are life-threatening incidents in which urgent intervention is indicated, and grade 5 is death. Now this is the severity, the grading of severity devised by the various agencies in US and UK who specialize in dealing with clinical incidents and clinical errors, as they call it. And there was one particular big study, the meta-analysis that I'm quoting here. It was a summary of 14 papers. Nearly 16,000 events were analyzed. And what they found was that about 15% of the events fall in the grade 4 to 5 category. But they also found that about 50% of these were avoidable. And that is the important take-home message from that study. Right, so we start with the webinar as such, and we're going to get all our panelists to discuss and share the incidents. And in particular, we would like them to focus on the ill effects of the incidents, the root cause analysis of what they thought was the cause of that particular incident, and how they change their practice, so we can learn that how we can prevent these incidents from happening. So if I may invite Dr. Subir Javeri to discuss his case. Subir bhai?
Yeah, thank you, Praveen. So let us go to the case. Can I have the next slide, please? So these are the X-rays of a middle-aged lady who actually presented to a colleague, and she had a little bit of a waddle in her gait, was tending to limp from the left to the right side while she was walking, and she did have a little bit of a slow gait, was requiring some support to walk. And so the orthopedic surgeon, can I have the next slide, please? Oh, so I think the slides have been changed a little bit. Can you go back to the first one? Right. So then the patient took some treatment initially, and then eventually she was counseled by the orthopedic surgeon for bilateral TKR. She underwent the bilateral TKR. Can we have the next slide, please? Yeah. So these are the post-op X-rays of that patient. The patient underwent bilateral knee replacement. Initially, there was some pain, some difficulty walking, which was well accepted. But by 2-3 weeks, 4 weeks down the line, she continued to have that limp, and she continued to have that waddle. So that was alarming. And the patient went back to the primary surgeon and discussed that, doctor, I was having this kind of a problem before the surgery. You did a very good surgery. The surgery went very well, but still my gait has not changed. So now the question is what are the reasons?
What are the reasons?
Where we would like to take a differential diagnosis as to what probably went through the surgeon's mind and whether there is something else that could have been there.
Can we just pause for 1 second, Subir bhai?
Yeah.
Let us see what our panelists think of the situation at this stage. Or
do you want me to describe a little bit of neurology with it, or you don't want me to?
Yeah, that we will come to later on, but at this stage, let's understand what are the possibilities.
You've let the cat out of the bag already. Let's have some comments from Dr. Matthew Varghese, what he thinks of the situation as it stands now.
A persistent waddling gait is an important post-operative thing you need to assess. So your assessment was the pre-op cause for the waddling correct assessment. So waddle means a bilateral lurch. That can be because of a knee instability with a lurch coming because of the knee instability. It could be because of a primary hip problem, or it could be because also of a neuromuscular problem. So if your pre-op diagnosis was based on the X-ray, this is osteoarthrosis, you treated it like that, you will not be able to get to the final assessment. So I would think in terms of, if there's a persistent, she's come to me, she's got a persistent waddling, I would first assess the knee. Is there anything in the knee that can cause a waddle? What is it in the knee that causes the waddle? A bilateral ligamentous laxity or a ligamentous balancing issue which is there, which can present with a waddle. That's the first thing I'll assess, assuming that the primary surgeon did his assessment correctly. Then I look at, if there is nothing there, I can find out. I look at the hip. Is there any arthritic condition in the hip which is causing a bilateral waddle? Bilateral hip arthritis, which can be missed. They can present with bilateral knee pain. Referred pain is possible. So that is the second thing that I would think into. Is that a possibility? The third thing, many of these elderly ladies have problems because of lumbar canal stenosis or disc release, causing severe canal stenosis related problems in the abductor muscle. That is the third thing I would think in terms of. So I go from distal to the hip, then to the spine, and I look for that cause.
So
There's one more thing that one must think in terms of a person presenting with a bilateral waddle. A severe osteomalacia can present with a proximal muscle weakness and also present with a bilateral waddle. So I would assess the patient from all these aspects clinically, and if necessary, by doing an assessment using biochemical evaluation, simply an alkaline phosphatase will give you a clue before I give a verdict on that.
thank you. So that's a very holistic assessment, and that's what's necessary. Let's see what Subir bhai did.
Right. So there were a few other thoughts as well. The patient, the history was said she was mild diabetic for last 2 months, 2 years. So there was that thought that there could be a posterior column dysfunction, or there could be a peripheral neuropathy along with that in this patient, which is causing the issue. The third thing was that the patient also had a Romberg sign positive. Now, a patient who has a Romberg's positive, definitely you start thinking whether there's a sensory perception problem, there's a posterior dorsal column involvement, or there is something else. And then when you examine the reflexes, it was a complete giveaway. The Hoffman sign was positive, the deep tendon jugs were all increased. And so this patient had a typical cervical myelopathy, which was unfortunately completely missed by our orthopedic colleague. So that is where the issue lies, that one needs. So these are the preoperative images. You can proceed for the eventually this patient underwent surgery and things were smoothened out. But the thing was, what I wanted to discuss here was that so many times our orthopedic colleagues just look at the patient coming in the clinic. They see the waddle in the walking gait, put a hand on the knees, check for the knee ROM and the crepitus. They do not bother to take up and put the patient onto the bed, or they do not even bother to put a reflex hammer and take a jerk and see whether there is any hyperreflexia or not. So simple, basic orthopedic investigations or neurological investigations would have avoided this mishap. But duty bound, obviously, we cover it up for our colleagues. It's our moral duty, and that's what we always do. But the thing is that if somebody would have, strayed, then this patient would have definitely gone in for a litigation, which is unfortunate.
Thank you very much, Subir bhai. So I think, yeah, that's a very important message, to examine the patient as a whole and not just as a part that we are seeing. Thank you very much, Subir bhai. The next case, I'm going to invite Dr. Nityanand Rao, the open fracture femur case. Dr. Rao.
Yeah. So this was my experience regarding a pinpoint compound fracture femur. This was, am I audible?
Yeah, yeah.
Yes.
Okay,
Please go ahead.
this was very early in my practice, and this was in 1996. I saw a young adult with a fracture femur with RTA. So the routine X-rays were done of pelvis and knee, and was found normal. His hemoglobin was 7.5. The other routine lab tests were normal. The HIV tests were done and was found non-reactive. So as the hemoglobin was low, 2 units of whole blood were arranged. Both the donors were brought by the patient's family. One donor was his brother and the other was his brother-in-law. The blood from the donors was screened for HIV 1 and 2 by ELISA and hepatitis, and both were found non-reactive. So the consent for blood transfusion was taken from the patient with all the information of HIV screening informed to them. And then 1 unit was transfused pre-op to the patient. And then normally those days we used to wait for 3 to 4 days before taking up long bone fracture fixation. So by the end of 4th day, we did an open reduction and internal fixation. And those days we still used to do the K-nailing procedure. And the second unit of blood was transfused during surgery. The intra-op and post-op was uneventful. The patient was discharged after 4 days following surgery. And the patient was advised for a review after 10 days. However, the patient did not come back. So what were the possibilities? Why did the patient did not follow up? Was going on in my mind when we learned from the patient's brother who walked into the hospital, said that there was a discharge from the operated wound and hence his relatives had taken him to a different hospital. And so while I was talking to him, what was going on in my mind was there an infection or what else? But then the patient's brother dropped a bombshell and he said in that hospital, the blood was checked for HIV and it had come positive, that is of the patients. So I was really worried because we had done the routine blood test of the patient and the donor. But here he was showing a blood report from which I did not believe that in that hospital it was positive. And then he took out from his pocket a blood report from 2 different labs of the same patient, which was showing that he was HIV positive. And he was told by the doctors in that hospital that we had transfused the blood without screening for HIV. And he now alleged that the patient had acquired HIV because of the negligence of the doctors and our hospital. And so, a little later, after about 3 weeks, we learned from the patient's brother itself, who used to come on and off, that the patient's brother-in-law had also tested positive for HIV. Now, the patient filed a complaint against the doctors, the blood bank, and the hospital for negligence with the Karnataka Medical Council and the District Consumer Forum.
Yeah, Nityanand, can we stop for a moment and like we have the opinion of others, like what could be the reason? So let's start with Dr. Maini. What do you think, like a patient who was negative preoperatively, how come he become a positive?
The possibility could be a wrong report, a mismatch of a report. The patient was actually positive to start with, but then due to a lab mixing, the report came negative.
So it's a false negative, like patient is positive, but because of some mistake, it was there. Dr. Prahlad, what do you think about this?
Definitely, sir. It's very unlikely that the patient has discharged on 10th day and he's getting positive within the short period. So it's very unlikely that it might have come from the transfusion, or as Lalit Mani sir was telling, like it might false negative might have been one of the cause, so that it was not detected in the previous investigation. And most often we take proper consent from the patient during the blood transfusion. So where we mention these things that That might be a window period when we take the blood sample from the, because we do all the cross matching and investigations from the sample taken to be transfused. So any transfusion risk, if the patient is in the, if the donor is in the window period, so it cannot be assessed.
Okay, so you think that the second possibility is that patient may be in a window period and that could be the reason. So first is false negative. That's a laboratory problem. The second is the window period. Okay, so let's see what happened later on. Yes, Dr. Nityanand, can you take over?
Okay. One should understand this was very early in 1996. And so the awareness of HIV testing was not as good as what it is today.
Yeah.
So the possibilities of what Dr. Maini has said, that a false negative or he was in the window period, is acceptable. So, but it is also pertinent to understand that the patient was screened, the donors were also screened, but of course, it was screened only in our hospital at that point of time and not cross-checked in another labs. And so at a later date, we found out that the brother-in-law also had tested positive for HIV. So the brother-in-law of the patient. So now the patient filed a complaint against the doctors, the blood bank, and the hospital for negligence. The blood bank was in our hospital itself. So with the Karnataka Medical Council and the District Consumer Forum.
Okay.
So then the ordeal started for us. The concerned government authorities from Bangalore arrived. They checked the patient records and all the paperwork relevant to the case in the blood bank, and they found it to be in order. Then the Karnataka Medical Council held an inquiry into the same. And so we had to rush to Bangalore 3-4 times, and we submitted all the documents as demanded by them. So what other possibilities could have happened at this point of time?
Okay, let's see what Dr. Abhijat said. Do you have any insight, any comments? Abhijat bhai? Ketan bhai?
No, I think we have got the two important points covered. Very importantly, when the brother-in-law came out to be positive, there is a reasonable possibility that the patient was in the incubation period somehow or the other. That could have been a possibility, because that we can't deny the fact. And initially was negative, and then the brother-in-law coming out to be positive. There's got to be some link towards that.
Right. Okay.
Can I move on?
Subir bhai.
Yeah. Just one thought. Sometimes these kits have an expiry date, and way back in 1996, if the lab had kits that were probably expired, the result may have been negative. So one has to be very pertinent when there's a lab also going on, that the reagents that these kits have, they have not been in the expiry date, beyond the expiry date. That's just a thought. Otherwise, the questions are already been taken care of.
Okay, thank you. Continue, Dr. Rao.
Okay, now we are all concentrating on the patient and the screening, the false negative, whether the kit was not okay. But what went wrong with us was we did not concentrate on the patient's brother-in-law, who was the donor, where the screening was done. And probably what happened was this donor was in the window period when he donated the blood. So that is how the blood transfusion went on, even though it was non-reactive. And probably when the patient, after 10 more days, that is about 3 weeks post-injury, has gone to another hospital, there when they tested the patient, he has come positive.
Right.
Any thoughts on this?
That was already been discussed. The window period was already discussed.
Yes,
Yeah.
but the window period of the donor.
Yeah, the donor.
Okay. So the Karnataka Medical Council found the case sheet and all the documents and blood bank were in order. They observed that the donor was the patient's relative and was brought by the patient's family itself. The blood was checked following all protocols and with proper documentation. The donor's blood, which was transfused, happened to be in the window period. And they said that there was no negligence by the doctors or by the hospital, which was beyond the control of the doctors or the hospital. But then they took it up with the District Consumer Forum. It went on for 5 years with our appearance almost every month. And then they ruled that the hospital and the doctors were negligent and fined rupees 2 lakhs. And it did not stop here. The patient then appealed to the State Consumer Forum for insufficient compensation in the District Consumer Forum. And then after 4 years, this State Consumer Forum is in Bangalore, and every month we had to appear for the next 4 years. And they ruled that only the hospital was negligent and asked the hospital to pay the fine of rupees 2 lakhs. Another few minutes dwelling into the story, the hospital approached the National Consumer Forum at New Delhi for relief. But this continued on for 3 years. And by that time, the patient relatives, accompanied by many politicians, came for a compromise, and the hospital paid them 2 lakhs, and the patients withdrew the case after 12 years.
My God.
Right, so that's a wonderful, yeah, it's a wonderful example of like, it's none of the problem. It's basically the patient is in an incubation period, and we really don't consider that every time when we give a blood transfusion. So Dr. Nityanand Rao, like, how did you change your practice after this?
Yes, so a few of the things is, the lessons which I learned is to dwell more into this HIV and its testing and to know more about it. So,
sorry,
I just lost it.
Yeah, so please now just you can summarize.
So I started thinking well before advising a blood transfusion, and I made sure that there was a mandatory screening for HIV, hepatitis A and B and C for the patient and the donor. And we make sure the importance of the eclipse period and the window period is explained in detail to the patient and also to the donors. And then we included this in the consent form along with the screening for HIV and hepatitis before transfusion. So education and documentation became more from us. So one should understand that as orthopedic surgeons, that blood transfusions are required in most of the orthopedic surgeries. So the orthopedic surgeon has to be aware of the risks of HIV and other diseases transmitted through blood transfusion. And experience on this pushes us to understand more about HIV testing, protocols, eclipse period, window period, and the need of detailed consent documentation.
Thank you.
Okay, thank you very much. Yes. Okay. Matthew, would you like to comment on something like the lesson you learned and how you are going to change your practice? Meanwhile, Praveen, can you switch on to the main presentation?
Yeah, let me get that.
Just one slide, if I'm permitted.
No, sir, we are running late, so we will come to that later on. Yes, okay. Matthew, your comment before we switch on to the presentation again.
The only thing that is probably need to be highlighted here is the informed consent when you're giving a blood transfusion. The risks of blood transfusion should be told to the relatives. These are the risks of blood transfusion. And if you have listed this as a possibility, then as far as the consumer court is concerned, you would probably be safer, because the courts, they look at evidence and have you written it down in your risks. Because I have been, as the head of an institution, a part of cases of my doctors are working under me, where the court has said, you may have explained, but you have not written down that particular complication in your consent form. So whatever complication is there, anticipated, sometimes it is impossible to list all of them, but the court expects you to do that. So if you anticipate that this is likely possibility and higher in the list, it might be worthwhile considering documenting that. Because the court goes by written evidence, nothing else.
Okay, so now we come to the next category of error or the adverse event which we come across in our practice. Next slide. So medication error could be like giving a wrong medication to the patient. You have prescribed X and the patient is given Y by the chemist, by the nursing staff. The second, the common error is improper dosage. Sometimes it could be a less dose, sometimes it could be more, and that can create a problem. The third complication or the error is giving a wrong route. The medication which is supposed to be given only intramuscularly is given intravenously, or vice versa, the medication for IV route is given intramuscularly. And the rare complication, not rare, I would say the more common one is a drug-drug interaction. We as an orthopedic surgeon rarely look into the drug-drug interaction. And because of that, we see sometimes a new type of complication on unforeseen complication. Next slide. So let me show you one research which we did. This is a medication called Medzol 40. If you look at the Medzol 40 is S-omeprazole, which is, we use it as a proton pump inhibitor. Now the same medication Medzol 200 is available as a itraconazole. The same name, only thing difference is the concentration. So the same name, the medication is different. And one more surprise, the same medication Medzol 400 is albendazole. So this is what the situation is. Like it's a same medication, and the surprising thing is like the drug authority, they allow such same thing and they allow it to be marketed. So we now come to the next point, and this is a case like a Sherlock Holmes, and I invite Dr. Prahlad Singhi to say about the case. What happened to your case, and then we will take it to the discussion. Yes, doctor.
Yeah, thank you, sir. Though we are all orthopedic surgeons here, so we come across a lot of diabetic patients in our practice. So I think so at least 6 out of 10 of our patients will be diabetic patients. So I will just narrate an incident which happened in our institute. So we had a lot of geriatric patients in our hospital, and we have a full-timer diabetologist who take care of all our geriatric patients or diabetic patients. So one incident happened like one morning, our diabetologist got 10 calls that all the 10 patients had an hypoglycemic attack. So he was quite surprised, like why all the patients had an hypoglycemic attack. So then somehow none were very complicated. So they were all managed by telephonic advice. And then he came back to the hospital. He just went through what happened.
Yeah,
but
before that, Prahlad, let's ask Prahlad, just a minute. Can we have the opinion of panelists? Like, what could be the reason? Like, all of a sudden, 10 patients going for hypoglycemia. That's, I have not seen such thing or not even heard. I am hearing it for the first time. So, can I ask Nityanand, what could be the reason of 10 patients going into hypoglycemia? Nityanand, your speaker is on a mute mode.
Your mic is on mute.
Yeah.
Yeah, okay.
So, basically, I think one should check what other drugs this patient these patients were on. He said most of the patients were diabetic, and so probably if they had any diabetic fungal infections, the anti-fungal drug must have been given. But what other reasons? Very difficult for me to tell without knowing the medical history in the patient. What other medications the patients were on?
Yes, Navin, would you like to say something? Yes.
Or if they are on the insulin and probably staff has not used the insulin syringe to measure exactly the units.
Okay,
exactly.
There may be a possibility of a higher dose of insulin has gone to everyone.
Right. That is what I was actually pointing out, that the insulin comes in two strengths, 40 units per ml and 100 units per ml. And if the patient is routinely using a 40 units per ml and by mistake the vial that they used was 100 units, 2.5 times the dose would have gone to each and every patient, leading to a hypoglycemia in all of them.
Yes, exactly, Subir. You have pinpoint the reason. Next slide, please. Next slide. So actually, this was a newer insulin, and that was basically used as a 100 unit per ml. So when it's a 100 ml unit insulin, we have to use a syringe which is meant for 100 ml. But instead of that, the nursing staff used a syringe which is for the 40 unit. So what happened, like every time when she was measuring the insulin, she was giving 2.5 times the dose of what is prescribed. And that was a reason of this, all of a sudden, all the 10 patients going into hypoglycemia. So that is the thing is like in our country at this stage, there are two types of insulin available, 100 unit per ml and 40 unit per ml. So nursing staff has to be very clear that depending on the type of insulin, about the strength of insulin, we need to use the same type of syringe. Any comments by the... Yes, Lalit, would you like to say anything on this?
Unmute yourself, Lalit.
Yeah, am I audible?
Yes.
Yeah.
Yeah, it could be a new staff coming in, a new trainee getting onto the job. So probably checklists are very important. The way the developed countries are having a lot of checklist on what vial it is and checklist on what patients they are and doses are. Probably getting in checklist would help.
Yes. Okay.
Sir,
So
Sir, I
yes.
just want to tell that usually this, as Subair sir has very nicely told that this thing, the problem was with the syringe. So usually this Basalog come with this syringe. So the problem what happened was the pharmacy guy did not give the syringe, and the staff was not aware that the syringe has to be used is different. So we have to identify where exactly the culprit is. So and most now in the US they have clear guidelines. They don't use 40 unit syringe. They use only 100 unit syringe, and even they give advisory that whenever you travel out of US, you have to make sure that you use proper syringe, because still there are developing countries which we still use these kind of insulins. So the point is we have to be very careful. This negligence, like if the patient would have gone and if something happened, then it could be a grievous medical negligence.
Yes, thank you very much, Dr. Singhi. So now I invite Dr. Matthew Varghese for giving to tell incident about his hospital.
Thank you, Dhiren Bhai. One late afternoon, I got a call from a hospital that their house surgeon in surgery has met with an accident sometime early hours of the morning on his way to the hospital. And he's having difficulty in moving his fingers now. And they are suspecting some problem in the neurovascular structure. So I do vascular repairs. So this surgeon knew about it. So he called up and said, do you think I said, send him over. By the time he came over, it was evening time. And I examined his brachial artery. He had a fracture shaft humerus, and his radial pulse was not palpable. I couldn't feel the brachial artery also. So I immediately suspected a brachial artery injury, ordered for an exploration, and took him up for surgery. And on examination, before anesthesia, we found that his finger movements were very painful. Paresthesias were there, and his arm and forearm both were swollen, and radial pulse was not palpable, brachial artery not palpable. We took him up, explored, fracture shaft humerus was fixed, but what we found was no neurological damage was there, but the brachial artery was contused and no distal pulsations were transmitted. We did a resection and end-to-end anastomosis and did a closed fasciotomy because there was a increase in facial compartmental pressure. All well, pulse returned immediately. We shifted him to the semi-ICU, post-operative ICU, and kept him under observation and maintained. The second day, again, it was my theatre day that day, evening, my house surgeon said, sir, there is some oozing from the wound that is there. So I said, fine, check if everything is all right. He's moving his fingers. By then his finger paresthesia had settled. He was started moving his fingers. Sir, theek lag raha hai. So fine. I was still in the theatre. By the time I came out and had a look, the house surgeon had changed the dressing once, and this dressing is also all soaked in blood. This is just about 30 hours down the line from the time of surgery. So there was definitely what looked like fresh blood. So
okay, so let's Matthew, let's ask the panelists what could be the reason. So let's start with Ketan Bhai. What do you think about the cause?
I had done a plating of the humerus, so humerus was stable. There was no problem there. I had done an end-to-end brachial artery repair. No graft was required, no vein graft, no other graft. End-to-end repair.
Yes, Ketan Bhai, what could be the reason?
One of the reasons, obviously, could be the giving way of the anastomosis.
Okay, right.
The number two thing could be the heparin or the drug medications which are going on. The dosing of those medicines needs to be considered. What all medications were going on, that could be a small possibility, but we have to keep that into consideration. I think I would directly think of these two reasons to begin with.
Okay, so the two possibilities, drug interaction and probably something wrong with the dose. Yes, Nityanand, what do you think about this? Please, yeah.
Other than this, was there any injury at any higher level to the
No,
brachial artery?
he only had a fracture.
They said they had done a plating and screw fixation.
Yes.
So can there be, could have been an iatrogenic fresh injury?
We didn't know because the patient was having a blood-soaked dressing on top. So I was seeing it from outside.
Most likely it must have given off at the anastomotic site.
So that is the first fear that comes to your mind.
Yes.
So anybody who does vascular repair, you have to anticipate there is a likelihood of a breakdown of the repair. But
Did he have
remember,
any other bleeding tendencies?
yeah. No, he had no other bleeding. He was a healthy house surgeon, active, getting on to his duty. He had no other problem, no comorbidities, nothing.
No
Young,
blood disease.
26-year-old house surgeon. No other comorbidities, not any medication, nothing else was there. So I was worried that maybe it has given way. But remember, this is something which was basic foundations in the early days of vascular repairs which they had found. A freshly repaired artery, it's not an absolute indication for internal fixation. It can withstand tractions also. So it usually does not give way. Give way of an arterial repair happens when there is infection. An infection usually happens more than 48 hours, 72 hours down the line. You may have a bleed, but usually secondary bleeds happen 1 week to 10 days down the line. That is when you start worrying. So I was reasonably certain that cannot be an infection in 30 hours time. Why is he bleeding? Why it shouldn't give up? I'm certain I've used the right material. Why is he bleeding? It doesn't make sense to me. So I felt that was, as Dr. Nityanand said, maybe I've missed another level of injury that is possible. So hesitantly, I opened up. Any other suggestion that you can think of? Hesitantly, I opened up and I looked at it. It was fresh blood oozing from all the edges of the wound. I said, that's difficult. But before that, I did something else. I palpated for his radial artery, pounding radial artery pulse. Now, if the repair had given way, the simplest thing to be done is to palpate for the vessel. Radial artery was bounding. I was relieved. Whatever it is not giving way of the repair that is there. But it could still be a pseudoaneurysm forming with a pulse intact. So but on opening of the dressing, I didn't find any swelling there, but oozing was from entire edge, even up to the area of the fasciotomy wound. That made me suspicious. Good pulse, edges oozing from edge to edge of the wound. I said there is something wrong. So I asked sister, did he get his heparin dose? Normally, I give a low dose heparin for these patients, which is 2,500 units 6 hourly is what I give post-op for about 48 hours only. After that, I discontinue it. 2,500 units. The usual vial that comes is a 5 ml vial. So it's a 2 ml dosage that we give. I asked the sister, ki kitna diya tha? She said, sister, this patient, doctor, this patient had received a 2 ml of the solution which was given. So 2.5 ml of the solution which is there. So I said, are you sure? So, just show me the vial. So just a presence of mind asked her to get me the vial. When I got the vial, she showed me the vial. Vial was a 25,000 unit vial. So this patient had received 2.5 ml of that dosage, which is 2,500 unit, which she thought was being given, but actually what she was giving was a much higher dose, because heparin comes in 2 different vials. I have these vials before me.
Yes, these are the pictures, Matthew. The pictures is all on the screen.
Yeah. So the pictures, one is a 5,000 unit vial and the other is a 25,000 unit vial. And the resident doctor who had written the dose had written 2 ml to be given for this patient, 2.5 ml to be given to this patient. And when he gave that, sister did not realize the dose per ml in that vial. She was giving him a 2.5 ml per dose 6 hourly, and that was from a 25,000 unit vial. So he was getting a toxic dose of heparin, and that was a lesson for me. I make sure every time I prescribe heparin for these patients, I always make sure, sister, make sure it is a 5,000 unit vial and not a 25,000 unit vial. I had not anticipated it. Until then, I did not realize it. But once I saw the 25,000 unit vial, now I check all the time. Today also, I went to my OT, got the 2 vials. The 2 vials, these 2 vials look very different. But the 2 vials these days look very similar in size also. It's 5 ml in 5 ml in both. One has 1,000 units per ml. The other has 5,000 units per ml. Huge difference. And you can get a toxic dose. I immediately stopped that, put him off heparin, his bleeding stopped, everything happily ever after. So,
Yes, thank you very much, Matthew, for a wonderful message.
the important message that is, the nurses have this rule of R's. The right medicine in the right dose through the right route, given in the right time to the right patient on the right bed. So all these R's, the 6 R's for nursing care is a very important thing that you have to check that everybody is getting the right dose. So such a situation, double check that the 6 R's for nursing care is taken care of.
Yes, thank you very much for saying the 6R. We will always remember that, or like we will tell our nursing staff to remember the 6R before they give any medicine. Thank you. Shall we move on to the next case? Yes, so this is about a CEO, a young dynamic CEO of around like 52 years old. He has a like lot of travel history. Of the 30 days in a month, he usually outside Ahmedabad for 15 days and sometimes even abroad also. Next slide. One day on Sunday, he was playing with his pet, and the pet all of a sudden jumped on him and he fall on an outstretched hand. And because of that injury, he sustained a fracture distal end of the radius. Right, it's a minimally displaced fracture, and he was supposed to go out of country after 3 days. So his doctor gave him a full plaster. And because there was no much swelling, and to avoid a swelling after giving a plaster, he suggested NSCID, which is a very standard story. So now I would like to ask our panelists, what do you think about the whole incident? That's a very standard routine practice which we see in our OPD. Like there is a patient, young patient, we give them a plaster, and to prevent inflammation, we give them NSCID. So I will ask Amin Saib, what do you think? What are your comments about this standard behavior which we carry out in our OPD? What do you think about this? Okay, let's ask Prahlad. What do you think? If you are in that place, would you do it something differently? Your speaker is mute. Yeah.
Shall I put the next slide? I think people will get a sense of the incident so they can comment.
Yes. Okay. So let's go to the next slide. So after 3 days, all of a sudden he had his urine stopped completely, and his serum creatinine report was 3 milligram per deciliter. Otherwise, he was a normal person, and all of a sudden there was no urine, and serum creatinine increased to 3. So what could be the reason? What went wrong in this patient?
So,
yes, Ketan bhai, what do you think about this?
I mean, looking at the investigation put forward, that is the urine stopped and the creatinine raised up to 3 milligrams, it is pretty much obvious that he landed up with a acute anuria, which would be suggestive of some renal inactivity, most possibly because of this plaster issue, because that is the only thing which happened in the recent past.
Yes. Okay, good. Lalit, would you like to say something about this? What could be the reason of anuria?
Again, the NSAIDs could be the problems which have created underlying renal disease which was there in this person, and that has
Okay.
precipitated the anuria. Otherwise, I think the only different thing we would have done is would have given a slab rather than a cast.
Okay, right. But that would not make a difference,
Yeah,
like
that
taking
would
the
not.
patient. So slab and plaster, they would probably not explain why all of a sudden there is anuria.
Yeah, Subir bhai is wanting to say something.
Yes, Subir,
Yeah,
please.
most likely the most common NSAID that general orthopedicians and we also in spine use is diclofenac. And
Yes.
diclofenac has got the first dose acute renal injury incidence, and it is known. So probably the person whom you showed probably had an NSAID or a diclofenac induced acute renal shutdown. Probably that is what has probably happened.
Okay. Let me give you the answer to the problem, like why he developed complete anuria. Any patient who is on ARB or the ACE inhibitor as an anti-hypertensive medicine, which is usually the first line of antihypertensive treatment nowadays, particularly in a young and active patient. And if these patients are given NSAID along with either of this antihypertensive medicine, that will cause a medical nephrectomy. And this is very common. So the message we want to give is we prescribe NSAID very routinely, but we need to ask a simple question. Are you on any other medicine? Because a simple medical medicine like ARB, angiotensin receptor blocker, or angiotensin converting enzyme inhibitor, this medicine can cause a complete or a medical nephrectomy, and that will lead to a serious problem. Ultimately, patient recovered, but it was a small error, small mistake on the part of doctor that resulted into a big trouble to the patient. Okay, so thank you. I now request Praveen to take over.
Yes, Dr. Mani, you want to say something?
Do you think, just a thought, do you think this points to a change of practice issue and maybe using paracetamol even in trauma situation, once you have splinted a patient, you can go up to 4 grams of a paracetamol in a patient. And once you have splinted the patient, the pain should go down. So I don't know, I was wondering whether it could be a blanket thing because you might miss out a history, the histories might be wrong. So I don't know, the panel can opine on this.
That's a very good point, sir. I think paracetamol is quite underutilized in our country. And as you rightly said, 4 gram is the highest dose, which is quite frequently used. When I was in UK, that was the standard practice. But here we hardly ever use that dose. And 4 gram is quite potent. So we can avoid these more dangerous drugs if we start with paracetamol in good dosage.
Yeah, Matthew, you would like to, you are like raising your finger.
Hello. Am I speaking?
Yeah.
Yeah, we can hear you.
The protocol that I use is any diabetic, any hypertensive, stay off NSAIDs and manage with paracetamol. My post-op patients, if I can manage, I avoid opioids, I avoid NSAIDs, and I manage with paracetamol infusions. That is the usual thing I want to do, except the contraindication to paracetamol is liver disease. So if there's a history of liver disease, alcoholic, then I avoid paracetamol. Otherwise, they can stay diabetic and hypertensive, stay off NSAIDs as per the that's the protocol.
Yes. Yeah.
Can I ask one question generally to the panel? This is relatively new to me because recently I've come across oral morphine being sold in the market. Which is it something new because it wasn't allowed previously in India?
Yeah, I also seen that.
Dr. Ketan Bhai has raised the hand. Probably he wants to say something. Ketan Bhai?
Yeah. So regarding this patient that we were talking about, I feel that paracetamol is definitely going to work if we are not going to take a detailed history. But do you feel that we should be supplementing it with things like trypsin, chymotrypsin to take care of the swelling part of the inflammation part? Does it really help?
Yes, paracetamol is not a good anti-inflammatory probably it will work only as a analgesic way. So fine, I don't think that paracetamol has at all a anti-inflammatory activity.
One point here I would like to add here. I'm not so worried about providing too much of anti-inflammation. Whatever swelling has happened has happened. That is the inflammatory process, and the cytokines and all those things have activated, and they have caused the edema, and the processes have already initiated. That has happened. I don't like to give too many. You are healing. They are also known to reduce potential effect. There also, the inflammatory process is a normal process of the human body before reparatory processes take on. So I don't think it is physiological to try to inhibit them too much. Use them to the minimum extent, because inflammation is normal to any reparative process.
Can I just have a show of hands? How many of us routinely use these chymotrypsin types of medications for fresh fracture cases? Because I find it quite interesting. I think
I never use them.
I use them.
Right.
I know I don't use it.
Okay. Dr. Mani, do you advocate using them in your practice there, or
No, not at all, because we don't get it in the hospital, and we don't believe in it, because once we splinted it and we are encouraging the patient to move the digits, so that should be more helpful than the chimeral force.
Right. Okay. That's good to know, because somehow I see it being promoted a lot in the market, but I myself don't tend to use a lot. So I just thought I'll ask everyone what your opinion is. Thank you. So I'll just shall we move on, or does anyone have a comment to make?
Yeah, please.
So this is just a brief incident again a long time ago related to the previous drug errors that we've seen. And this was, I'm going back nearly 20 years ago, when there was a post-op case after a routine long bone fracture fixation. And the patient was prescribed IV diclofenac, SOS. And this particular patient had the medication on the day he was due to be discharged. The night before, he had this medication and complained of severe pain in his little finger on the next morning when I went for the ward round. And so I kept the patient for observation for the day, because I could not really understand why the pain had suddenly increased. By the evening, he had started to get gangrene of the little finger, the tip of the little finger. So there was a lot of inflammation, redness initially, and then in 5-6 hours time it started to get blackening of the tip of the little finger. And then I made some inquiries with the relatives and with the nurse as to what had happened. So this patient was prescribed diclofenac, and the relative told me that there was some difficulty in giving the IV. So the cannula had probably pulled out. So the nurse gave just an intravenous injection without the Vigo. And she's had to make 5-6 attempts as per the relatives. And what had happened was the injection had gone intra-arterial instead of intravenous. And this is a relatively rare side effect. I'd not come across this particular or even read about it till then. And the incident resulted in the patient losing the tip of the finger. And the learning point, I guess we can discuss how we can prevent. I think it was 20 years ago, but is it still relevant in this day? That kind of complication? Ketan bhai, what do you think?
First of all, that long back anyway, till the time I know, IV diclofenac was definitely not on. Even today, I never use diclofenac IV. Even in a pint, I don't tend to use it. I have always orders given to use it intramuscularly. Though the aqueous form have come out through a few pharmaceutical companies, my simple rule is never ever give diclofenac intravenous as well, because it has been known to create a problem, especially the oily ones used to create the thrombophlebitis and all that stuff. So obviously, if it has gone in accidentally intra-arterial, it's going to create some more havocs.
Absolutely. And obviously, I have changed my practice as well since then. But this was 20 years ago, and I don't know if people still do that. But as Ketan bhai said, it's probably not a great idea to use diclofenac IV if you can avoid it, or if you have other means of controlling the pain. Any other comments somebody wants to add, or shall I move to the next section? Okay. So let's move to.
Also, there is no directly inject through a needle, because it's far better to have these injections in a running infusion rather than through a needle separately.
Absolutely, absolutely. It was meant to be given even in those days through running infusion, but this was an error that somebody had tried to give it as a stat. But yeah, I think that's an important point. So moving on to the surgical events or the surgical problems, we've all heard of never events in surgery. So what does it mean? It means surgery on the wrong patient, or surgery on the wrong body part, which may be on the wrong side surgery, or in case of, say, spines, for example, surgery at the wrong level, or the wrong procedure itself being performed. And lastly, if there is a retention of the foreign body, and again we'll come to the checklist and all later on, but these are all classed as never events. And another never event is which is less well known, is death in an ASA grade 1 patient. So a fit patient, anesthetically fit patient, who happens to die for whatever reasons, is again classed as a never event, which should never happen. So when we look at the NHS data, they have all their protocols and checklists. Despite that, they had 435 never events in this year from April 19 to 2020. And I tried to look through the Indian data, but unfortunately there is no homogeneity, and I could not find anything on the internet on the prevalence in our practice here. But just a ballpark figure, if we extrapolate the numbers, our population is about 20 times that of UK. So we can say that we had probably around 8,600 never events in our country. But then we need to bear in mind that there is no obligation for anybody to report these never events, and there is no central nodal agency that actually collects this data, because there is no uniform audit that goes across. So we need to take these figures with a pinch of salt. I'll just have a pause here. Having seen what is a never event, I would like to ask our panelists if anyone has come across these never events in your practice.
Yes.
Anyone? Ketan bhai, yes. Ketan bhai?
Yes.
Okay. Yeah. Sorry, I thought you raised your hand. That's
Okay, so he's trying to say yes. Let's put it other way, like who has not seen such never event in the career, in the professional career? Okay, so almost everyone has seen such error.
Yeah. So I think Ketan bhai will go through some cases of never events, and we'll start with Ketan bhai. He has a case to present about a child with a fracture femur.
Yeah, basically this was a boy about 8 to 10 years old, and it was a Saturday afternoon OT, and he was taken in the operation theater, induced by the anesthetist, and the OT sort of assistant, I would not call him the assistant, the person who sort of helps around, the helper, just started painting it, so as to say, on the left side without really confirming with anybody. And then the surgeon just walked in and saw the painted leg and inserted the Steinman pin, which was the procedure to be done, because after putting in the Steinman pin, he was to be put on a Thomas splint, which was the routine treatment during those days for a child of about 8 to 10 years old. So by that kind of an accident, because the surgeon never confirmed with anybody else, the anesthetist had induced and there was no confirmation about the side, just because it was painted by the helper, so as to say, on the left side rather than on the right side, which was the side of the fracture, the surgeon just walked in and painted on, sort of put in the Steinman pin on the painted side rather than on the actual side. So that was the accident which I came across.
Right. Okay. So that's an important thing. Anyone has a comment to make on what happened there?
Dr. Praveen?
Yes, sir.
Hello. I'll just give a very short and then I'll go out because I have to attend another day. Now, I'm very happy the way you all have discussed this different events. Now, these has happened in the past. These are has still happening. That this is still going to happen. The only issue which, as an administrator and as a policymaker, when we think that eventually we all have to develop a system and system of accreditation, system of and a culture of safety, and we have to let us take an example like you have described many medication errors.
Yeah.
Now, this we have built up a system in Apollo with all these different medical errors under heading, and I can tell you that despite building up a robust system, still the problem happens because it needs a continuous monitoring, it needs a repeated audits, it also needs education to your staff, and it needs again an individual insight into the area that this problem never happens while you are conscious and aware with it. It usually happens when you think that this is never going to happen. And I think the most of the time this has happened. So what like I'm also on the governing board of the NABH.
Mhm.
And I think now we are in the transition that majority, even the smaller institutions have came up with this sort of patient safety, awareness, culture. All associations are doing it. And I'm so happy that today you have selected this topic. And please let me know if on behalf of the NABH or on behalf of the DNB board, if I could be of any help to your association in coming future. But the only message which I will give it to all of you, we need to develop this, and we have to make sure that this has to be a system based. This cannot be an ad hoc based or just a randomized practices. These practices will have to integrate into our day-to-day clinical scenario, and you will see the difference. You will see the reduced number of these incidences. As I said that I am also not uh, out of this problem. I also faced all sorts of problems you have described, and
Yeah.
so the all of us. So that is my message to all of you. And thank you very much to all of you.
Dr.
Yes,
Matthew wants to say
before
something. Yeah.
Thank you very
Yes,
much.
please.
before Sir goes, I just want to put in a point here. The only way, in fact, that is the beginning of this, to prevent such missed events, never events, and adverse events is using the checklist manifesto. And I have been part of this checklist manifesto protocol development and the checklist for safe surgical checklist and trauma care checklist. Both I have been part in the evolution of it, and both can make a difference to our complication rates, to our adverse events rates, and for safety of our patients. I just want to highlight that. And if, as NABH, can push across the trauma care checklist and the safe surgical checklist across all its institutions, it will be worth the effort in terms of safety and comfort of patients. Forget about the consumer and the legal aspects.
Fabulous. Can I just make a little point here? Dr. Seth made excellent suggestions, and I think that is the whole purpose of doing this program, is to push for a system-based approach. And if I can request Dr. Verghese to email the PDF of this document that you just showed
Yes.
to Dr. Navin Thakkar, we can actually
In
put
the
this.
development of both.
Yeah, and we can just put this on our feed now, and people can just download it as they are watching this webinar. I think that will be great.
Okay.
You can supply me. I will put a link on the website and they can download.
Okay, I'll do that.
Just supply me the PDF. We'll put a link there. We're putting in the Google Drive. They can all download that. And somebody has asked, is there a WHO surgical guidelines?
Actually, if you just go, these are WHO guidelines.
Okay.
So if you just go onto the WHO website, there are two PDFs that are downloadable, free, not a penny is charged. One is a safe surgical checklist, free download, and that's a single page. The other is the trauma care checklist, that's again free download, WHO website, WHO international website.
Okay. Fine. That was a question from the audience. That's why I asked you.
Yes.
And Dr. Tharadra has commented in one of the case, there is a possibility of myoglobinuria due to compartment syndrome in one of the case you discussed.
Yes, I think the renal failure case.
A renal failure case.
That was
Yes,
being
yes,
discussed.
yes.
Right. Thank you very much.
Thank you, Dr. Praveen. Thank you, Dr. Nitin, Naveen, and I will now
Thank
go
you,
out of
thank
the
you.
webinar.
Abhi, thank you, Abhi,
so
thank
much
you.
to
Abhi,
all
thank
of
you
you
on
so
behalf
much,
of Gujarat Orthopedic Association. Thank you for accepting the
Thank you.
invitation. And
Thank you very much.
And Dr. Ketan Bhai has raised his hand to say something, I think.
Thank you, Dr.
Sir,
Shiv.
when
See you later.
about these checklists which Dr. Varghese mentioned, I think everybody of us has possibly now gone through the very popular book by Atul Gawande
Yeah.
regarding the checklist manifesto. So I think
We had already wrote to him to have a part of this webinar, but we could not get his response probably.
I'm just mentioning it because it's a very popular book among the doctors, especially.
Yeah.
So I'm sure Dr. Varghese would have, with his experience and knowledge, would be much better off. But at least this is a commercially viable thing, which a lot of non-doctors also have started reading and inculcating those points as far as possible, even in their businesses.
Yeah, no, that's a
Ketan
fantastic.
Bhai, Matthew Varghese was a part of that study. So
Exactly, sir.
Time I'll give a little explanation and the full story on it.
True, sir. Please go ahead.
Right now,
Shall we do it?
Matthew, can we do it at the end because still we have a lot of cases.
from the
So
end.
what we'll do is, I think when we are doing the discussion after this, we can probably do that.
I'll do it in the end.
Yeah. Thank you. So Dr. Anand Joshi could not be with us because of internet problems, but he had a case to show about the wrong side implant being used in a knee replacement. So instead of the right femur, somebody had put in a wrong side, the left femur in a total knee replacement. But he's not with us, I don't think. So
okay,
let's move to the next case.
Just
Dr.
going
Lalit
back to
Mani,
that.
sir.
No, among the panel, have you heard of such a thing being done? Anyone?
No.
I have heard. I won't name the surgeon, but I've heard it being done. What happened? The surgeon kept quiet, carefully kept following up the patient, and so far there's no problem.
that is also a possibility.
Yeah, I mean, that is absolutely, it's a possibility. But the point, I think the larger point to consider, and we will discuss this in more detail, is the duty of candor. And we'll discuss this towards the end of this section. I think it will be an interesting discussion.
I think it is a operating surgeon should say first rather than the other surgeon say first.
Yes.
Absolutely, absolutely, sir. Dr. Mani, shall I put your slide up?
Sure. I've also seen a wrong femoral component done, and that was actually front side back. So the anterior flange was posterior, and the posterior part was anterior.
That's an absolute.
You have to come back for a revision.
Right. Okay. Is the screen visible to everyone now?
I have seen that in the live surgery, the assistants give a wrong side of the nail, but it was changed immediately. That happens everywhere.
That happens, right? So we've skipped the patella side, sir, because there was some duplication of cases in terms of wrong side surgery.
Okay. So this is a case, a bilateral fracture calcaneum in a 22-year-old male. One side was needing an open reduction and fixation, and the other was for a closed reduction and fixation. So the closed reduction and fixation side was planned for surgery, and patient consented because the other side still had swelling related issues. Now, the plan was to operate him prone because the posterior tuberosity was the part which needed to be reduced. So due to the prone position, the wrong side got prepped. However, the mistake was picked up on the first yam shot itself, and you got to know that you're not on the right side. So the thoughts, this prone position and lateral position can get you stuck at times if you yourself or a responsible team member is not supervising. And prone is definitely one area in which your thought process goes upside down. Now here the problem was both lower limbs were marked since the call for which side had to be operated was delayed too long. In fact, the OT list carried the comment that both sides had to be operated. So
Right.
what thoughts came out was imaging at the start of a case may be a good practice in many trauma scenarios. And it will also tell you a secondary thing that your C-arm is not out of order.
Right.
So that's a short case I wanted to share.
You can share this one as well quickly while we are at it.
So you want to see take the next one also?
It's the wrong side. Let's move on to the next one. Let's move on with the
This one,
presentation.
this was again a wrong side.
Yeah. So we've got a few examples of wrong side surgery. Okay, so now I think is the important discussion about how to avoid that. We've already touched in slight detail about the WHO checklist and all, but I would just like a sense, some comments from all the panelists about how to avoid wrong side surgeries. If I can start with Dr. Javeri. In spines, what precautions do you take to make sure that you are at the correct level, sir?
Right. So pre-operative X-rays are something that we always make sure, and so many times we end up with the MRI being quoted as having the L5 sacralized or the some lumbarization of S1. So transitional vertebrae is the one that tends to have the biggest of trouble. Is my case coming up on that one? We are not having that case. The one that I sent for the transitional vertebrae.
No, we have not put that one on.
Fine. So then I'll just quickly summarize the
You can
transition
summarize
part.
that. Yeah.
Yeah. So many cases we have the L5 being sacralized. Sometimes if the patient has had a full length MRI, then there would be a note that the S1 is actually lumbarized and not the L5. But that always creates a lot of trouble. And what we have come up with is what is known as the last mobile segment, what is known as the LMS concept. And whenever one is doing surgery, pre-operative X-rays are compared to pre-operative MRI, I tend to label the vertebrae on the X-rays because intraoperatively the X-ray is going to be our friend and it is going to show your correct level only on the CR. So the X-ray is numbered. I also put small arrows that this is the L45, which is the problem level, and this is the last mobile segment because L5 is sacralized in this case. So that is exactly how we make sure that the levels are not wrong. Second thing is if we are at the dorsal lumbar junction, then you have to anticipate that what is the situation of the 12th rib. So there are two things that is always to be noted. One is the L5S1 or the last mobile segment, and the second thing is the 12th rib. If it is thin and tiny, then the 11th is the largest rib. So that way you can count your levels. If you're going into the thoracic spine, then you don't make any mistake, especially when doing ossified ligamentum flavum cases where there is no outward indication like a fracture to get to the exact level, and then you have to be very precise in doing it.
Thank you so much. Thank
Yeah.
you. Dr. Nityanand Rao, can I have some comments from you, please? On what do you do to ensure correct side surgery?
Basically, one has to see the patient before because most of us rush straight to the OT thinking that our juniors would have done the correct job. So that practice we have to get away from. We have to see the patient first before surgery and see the site and then see the x-ray and mentally prepare for that surgery. When there are 4 or 5 surgeries, if you try to do too much at a too little time with too much of stress and too much of doing too many things, that is where the problem starts. So before surgery, one has to be mentally be prepared. The third, like what they showed was, Dr. Maini said, when your position is changed, the site changes. So that has to be kept in mind always. And before you start the surgery, just like what Dr. Matthew Varghese has said, the checklist is very, very important. So now we have that habit of writing it on the board and the sister calling it out before we start the surgery. So all these things and the checklist and the surgeon's involvement always, and not blaming it on others and leaving it to others. We are operating and we have to take care of all these things. So I feel this is the most important thing. Avoid doing on the wrong side.
That's a great point. Thank you very much. Dr. Mani, would you like to add something else?
Do I say something?
Yeah, would you like to add something?
Yes, I would like to add something. We even started asking the patient who is in regional anesthesia, which limb bhaiya, kindly reconfirm once. And then what happens if you've done a wrong side surgery? You've done a wrong side surgery now. What happens? Now I'm working in an institute in which I get new postgraduates and new senior residents every year. So we actually have a profile of missed injuries happening when they come, and the residents are changing. So once a wrong side surgery has happened, it is a protocol that we do an internal departmental inquiry.
Right.
Even if the patient doesn't complain, we do a departmental inquiry in which the residents involved or the teachers involved or the team involved is summoned and asked questions. This re-emphasizes an environment of importance in the department. We further go ahead every year almost and ask them to present a seminar on wrong side surgeries, so that it is very important and this gets embedded into the whole environment of the department.
That's great. I think, and that's where good leadership comes in. All the postgraduates coming out will have the same mindset of what you're teaching them. So I think, that's very important.
Yeah, Matthew, please.
Wrong side surgery prevention starts from the ward from where the patient is being shifted. So the house surgeon who's taking the consent, he talks to the patient, marks the right on the consent form. If it is the right side, right on the consent form. The nurse and the doctor together marks the side that needs to be operated. So in the ward, the preparation of the side is as per so the patient is conscious. A conscious patient, the wrong side is a little more difficult than an unconscious patient. So where do you have to be extra careful? Unconscious patients. Where do you have to be extra careful when bilateral sides are there? So you need to be aware of where are you likely to make a mistake more often. Unilateral, conscious patient, obvious deformity, obvious visible problem, you don't make a mistake. Bilateral, no external deformity, for example, arthroscopies, no external deformities, no visible changes in the skin or in the osteoarticular structure, then again be very, very careful. Then when the handing over takes place in the theater, the handing over nurse says right side surgery, the taking over nurse says right side surgery. And then once the patient reaches the anesthesia, pre-anesthesia room, there's supposed to be a huddle. In the huddle, the nurse says right side, the anesthetist says right side, check the consent right side, surgeon says right side, patient says right side. Everyone agrees right, all right. If there is even one division, you recheck, is there anything wrong? The patient is the ultimate person who decides. Sometimes patient may not know. He might not know, especially in spinal surgeries. In some of these cases, you may have whether you need to go to the right side or the left side. The patient may not know exactly. So you need to be doubly checking all these things. So it is at different levels. Prone position, again, be aware, double check again, because you can make a mistake. So you need to know where you're likely to go faulty and where you're likely to be double checking, triple checking to be sure you don't make a mistake.
Thank you so much. And I think all the delegates listening to this talk, that's a fantastic pathway Dr. Varghese has just described. And the important point that Dr. Rao also made and Dr. Mani also made was that the buck stops with you as the surgeon. And I think it's very important, if you have to take one take home point from the whole of this discussion, is that ultimately it's your responsibility to check the correct side surgery, and do not delegate the limb marking to someone else unless you trust them with the surgical procedure as well. So moving on to the next segment of our presentation, I'll just present, I don't have any x-rays, but an interesting case of a proximal humerus fracture fixation, which is probably about 6-7 years ago now. And this was a very standard proximal humerus fracture for Philos plating. And the procedure was uneventful, plating was done, and the skin was closed as normal. The day after, when the check x-ray was done, we found a little piece of metal around the just above the deltoid, just above the deltoid insertion. There was a little piece of metal. Now we went back to the theater and we checked the checklist, as we call the WHO checklist. All the checks were correct, the sharps were accounted for, the swab count was correct, and we had a discussion with the nurses. So where did this loose bit of metal come from? And it looked like a piece of broken needle. So then I had a chat with the patient. I explained what I'd found on the post-operative radiograph, which was not expected and which was not known by anyone. So we gave the options to the patient, whether, you know, this might not do any harm. It's only about less than a centimeter, but equally it's a sharp piece. It could cause some potential problems in future. And in consultation with the patient, we then decided to explore and remove that piece of metal, which turned out to be indeed a piece of a broken needle, the tip of the broken needle. So we had a root cause analysis. Obviously, this was a never event in the sense that a foreign body had been found in the patient after surgery. And what had happened was the WHO checklist at that time mandated that you check the gauze swab count, you check the number of sharps that include the suture needles, the hypodermic needles, and all the other needles. But it did not mandate that you check the completeness of the needle. So what had happened was, inadvertently, during the deep tissue closure or the subcutaneous closure, wherever the tip of needle had got broken off. And by the way, it got reported to the manufacturer as well, because this should not happen. But this had happened because the checklist did not incorporate the completeness of the sharp. And we then, as an outcome of the root cause analysis, we amended our WHO checklist and we sent this recommendation to WHO as well, that this should be included. And the subsequent revision, they have included the completeness of the sharp to be removed as well. So this is just something that I wanted to share, that it's easily done and may not be realized unless you do a post-op X-ray.
So, can I make a comment here?
Absolutely, sir.
There are practices in certain hospitals where they take a X-ray image before extubating or wheeling out a patient. And we, in our trainings, have been following this protocol of getting a check X-ray next day. So probably it's a wise decision to take a Siam shot on all sorts of cases before the patient is wheeled out, because if there is something of worry which needs to be taken care of, it is done in the same anesthesia. I've seen one peculiar example when I was in a fellowship in Japan. They did a revision hip and they checked the post-op Siam. And I was wondering why they're doing this. They said it's a protocol. And to our surprise, an extra head was lying inside in the soft tissue. So the first hip which they had revised, the head of that hip was inside. So probably another change of practice of taking one X-ray shot at least before extubating or wheeling off the patient might be very useful as far as the patient perspective is concerned.
No, I think that's a very useful suggestion. Yes, because what happens is many a times at the end of a complex 2-3 hour surgery, you are just happy to get out of theater after getting the last X-ray shot of the fixation itself. But I think that's a very useful suggestion to do an X-ray.
Can I narrate one incident?
Yes, please, sir.
My video is not working. We also had one similar, but we had the practice of doing an X-ray at the end of the surgery, and it was a case of fracture neck femur where a cemented prosthesis was done, and to our surprise, at the end of surgery, we found a small piece of cement lying inside the joint. So, piece of cement, bone cement.
Right, right.
And because the patient was not out of drapes, means he was not, though the wound was closed, the rest of the things were not disturbed. So we opened up again, removed that piece of cement, which would have caused a lot of problems subsequently.
Thank you so much, sir. Again, I think anybody listening, it's a very useful suggestion. Before extubating the patient, get an extra shot of this surgical part, and a C-arm shot, sorry, of the surgical part. Anything else panelists would like to add? Any suggestions? Okay, so we've already discussed how to avoid. Can I invite Subir Bhai again to discuss this interesting case of his?
No, I will be discussing because now we want to run slightly faster. So I will take over from here. So this is a VIP syndrome which usually occurs, and VIP are basically the patient, whatever complication we are expecting or we have heard of, this usually occurs in this VIP group of patient. May I have a next slide, please? So this was about a lawyer, male, 72 years. The diagnosis was very clear. He had spinal canal stenosis. He was tried a facet block and it was not successful. So he was advised surgery. Next slide. So he underwent interbody fusion at two levels, at L4-5 and L5-S1. The surgery was uneventful. It lasted for 3.5 hours. There was no hemodynamic problem during surgery. Next slide. The problem started after surgery, the 3 hours of surgery. Initially, patient had a watering in the right eye. Later on, he developed, after half an hour, redness in the eye. Then after half an hour, patient complained that I can't see. So immediately, ophthalmologist was summoned. He suggested to start steroid and a topical drops. Again, there was no response to that. So patient was rehabilitated by a senior ophthalmologist. And he said that let's give a rest to the eye. And so he gave a patch to the eye. Next slide. So now we are trying to understand like why this happened, why all of a sudden patient lose a vision in one eye after surgery. So if anyone would like to ask, start with the comment, Matthew, yeah, I saw that you are trying to answer that.
Prone position patient, normally the anesthesiologist, they'll put a patch on the lid or put a patch on the eye so that the eye is closed. In prone position, while shifting into the prone position, maybe the eye patch has gone and the cornea must have been exposed. The red and the irritation and the watering is clearly an evidence of a corneal dryness which happens because of constant exposure of 3.5 hours of prone position is a very long position for cornea to be exposed without blinking or without closed lid. So the common problem that you must anticipate in a long anesthesia is the eye properly lid covered? If it is not, be prepared for a corneal ulceration, corneal dryness, secondary to corneal dryness, and you are likely to face this problem. There's one more problem which I'll take on later on, but in this particular case, because there was clearly irritation, redness, and difficulty in vision, because at that time they'll have blepharospasm, they'll have problems in relation to the irises because of the corneal ulceration, they will have problems. So vision problem in this particular case is most likely secondary to corneal drying from prone position, uncovered cornea.
Okay, Prahlad, would you like to add something to this? Any other hypothesis like what is happening?
It is a very common complication. It is a documented complication in the spine surgeries following the long prone position, as Matthew Verghese sir has already told. I think so. There is one more component of optic neuritis. Like there is an optic nerve edema which gets, and that produces blindness. And I think so. This is a well documented complication of prolonged surgery in the prone position.
Yeah, I will add on here. I wanted to talk about this complication a little later because I have seen one patient. This was a patient of poliomyelitis who had paralytic scoliosis. This was a patient who had come all the way from Kanpur, severe scoliosis with pain now. She was a 60-year-old lady with painful scoliosis. And my goal of surgery was to manage her pain. But she needed multi-level fixation with spinal fusion. The surgery lasted about 4.5 hours. I did the surgery. Post-op, patient could not see. I thought of corneal dryness and problem. There was absolutely no problem in the cornea. I was petrified. Now, this is a complication which I had not anticipated. Patient was really petrified. She came for a painful back and she could not see. So I got the ophthalmologist in line. And though I had heard of such a possibility, I'd never seen one and never seen any of my colleagues talking about it. I talked to the ophthalmologist. He said, yes, sir, this is a rare event which can happen from prolonged prone position, which is possibly because of some optic edema that happens because of that position. This patient was put on steroids. Luckily, she regained her vision. Luckily, there was a full restoration of vision. Probably we picked it up in time, we put on treatment, and she was on long follow-up. And when I saw her almost a year down the line, she was happily walking around, pain had gone, vision was normal. But this may not be true in all cases because the literature is talking about a rare event, but as a possible event.
Okay, thank you, Matthews, for sharing like experience. Let's see what happened in our patient. May I have a next slide, please? So the possibilities are like patient had hypertension, diabetes. So that could be one reason, but we can't explain the mechanism why it leads to blindness during surgery. The possibility was inadequate padding was a likely possibility. As we discussed, the prone position itself is responsible for an optic nerve injury, or probably an intraoperative hypertension could be the cause. However, the operative record says that there was no hypertension less than 100 millimeter of mercury during any time in the surgery, or the rare possibilities like the thrombotic phenomena. So these are the possibilities. We don't know actually what is the cause. Next. So coming to the what happened over a period of time, the claudication improved, for which the surgery was carried out, it improved. However, the patient was not lucky like the Matthews patient, and the vision loss persisted even at 1 year or even at 6 years also, that Subir told to us. Patient started his practice, he was an advocate and he started his practice, but because of single eye vision, he could not drive. So this is one very serious complication, and it leads to so much of disability to a person. Patient has come to us for something else, and we give them an unwanted gift as a byproduct. So what are the possibilities? Subir, would you like to say something about like what was the ultimate possibility?
Right. So basically, this patient, what we had to do is what I had to like sit down with the patient, tell him that this one of the rare complications of spine surgery. Although it has been documented worldwide, there was adequate padding, everything was done according to the book. But yeah, the entire case that I had sent, there is also a mention about the headrest. So what happened in this patient was that the patient who had a very heavy and a big head, and the normal headrest that we have at our hospitals is kind of fixed headrest. But this patient was operated at tertiary care, where it was a modular type of a headrest, and there is a possibility to have the headrest by the side. And despite my recommendation, my instruction, I had requested the anesthetist to adjust it, but my mistake that I did not check that it was done. The headrest was not widened enough, and one of the headrest kind of put pressure on one of the eyes, and the other eye was fine. And that pressure compounded with hypertension and diabetes led to an optic nerve involvement, and that nerve we lost the function of that side completely. It took a hard time. Whenever we have met, he is always overall quite happy with his back surgery outcomes. But then we always discuss that in Gujarati we call it Bakru Karta Oont Pethu. That means while trying to get the goat out of the fence, the camel got in. So that is something we always share anytime he has come back for follow-up. But you have to be very truthful to the patient. You have to sit down with them. You have to tell them, and you have to give your best possible reassurance. And you have to be very, very, very cooperative and hope and really hope that he does not go to a court of law, because
Yeah.
there is no way you can defend this in a court of law.
Yeah, just to be like, I would like to ask, like, for how many days you could not sleep following this incident took place?
It's very difficult. How many days you cannot sleep, but the thought process of you being responsible for something that a patient is going to expect for the rest of his life, that itself is devastating. At least for the first 2 to 3 days, uh, you just feel so bad that you don't want to do any surgery anymore. And this is actually one of the least complications. If you see the kind of work that we do in spine and some of the kyphotic cases, there is always that fear of them getting paralyzed. And so those are the real bad cases. And even going before surgery in such cases, the day previous also we do not sleep. That's actually a fact, because it gives you it's really what is known as the coronary clogging surgeries. That's what one of our senior spine guy calls them, the coronary clogging surgeries. That's what he calls them. But it's painful. It's very painful for the surgeon as well.
Okay, thank you. Shall we move on to the next case? Yes, next, please. Yeah, so this is a case contributed by Dr. Prakash by Amin. It is about a non-union of a scaphoid fracture in a young patient of 24 years. Next slide. Under supraclavicular block, the surgery was carried out and the surgery time was 1 hour. The tourniquet total time was 50 minutes. However, the problem started after surgery. There was no motor or sensory recovery even after 6 hours. The patient was operated in the afternoon, but even at 8 p.m., there was no recovery in the motor or the sensory part. So like they waited for 24 hours, and even at 24 hours, the anesthesia persisted in the whole arm. The motor grade power was 0. However, the pulse was normal. Fortunately, there was no hematoma in the axillary area or in the supraclavicular area. Next slide, please. So now coming to this, what could be the reason for this problem? And Subir, I know that it's not your area, but would you like to say something on that?
Well, basically the tourniquet pressure is what leads to this kind of trouble. And if the pressure gradient is very, very high and it has not been calculated, initially when we used to, like during the learning years, we used to just have the handheld tourniquet pump and there was no way to gauge the pressure that was there. Nowadays, we have the sophisticated all equipment where it does have a pressure gradient at how much is to be and this much above the systolic is what should be the systolic pressure in the tourniquet. But perhaps that gradient was not there, and suddenly, if a very high gradient is given, a pressure gradient, then that can cause complete cessation of all neuronal activity, along with the loss of the vascularity to the nerve as well.
Okay, Prahlad, would you like to say something, some possibility? I know that we can't say 100%. So Subir said about tourniquet. What do you think?
So, during our post graduation, we used to use rubber tourniquets, so not the pneumatic tourniquet. So a kind of edge mark rubber tourniquet. So then that is one thing that can produce. We have seen sometimes this kind of situation. The other, I don't know, like maybe if you have used some drug which is outdated, or maybe it has some kind of contamination or preservative which could have irritated the nerve, and the block might have extended. Maybe that one perspective of looking into this.
Okay, Ketan bhai, would you like to any hypothesis about the mechanism?
I'm reasonably sure this could be most likely because of a tourniquet pulse, because I've had a similar incidence of a anesthetist sister who was going to get married the very next day, and we took her in for a radius ulna fracture because obviously it was an emergency thing, and we were using the manual tourniquet, and the same thing happened. The very same thing happened, and we were like, we didn't know what to answer. So
Okay. Okay. So
Can I come in there?
Yeah, can I?
yeah, please. Yeah.
Can I? There are many times a problem with the anesthetic agent with the preservatives. Many times, that creates a chemical effect that is has been shown in the spinal also. And there is one question from Dr. Tejas Gandhi about this post-spinal anesthesia sciatic nerve palsy in TKR. Any experience on how to diagnose and conclude? Even
Okay,
in
that we
TKR.
will, yeah, that we will take it later on. We will ask Dr. Maini about like how to deal with that. So
Can I-
Matthew, yeah,
Can I add something?
yeah, please.
The clinical examination of the patient will give a clue to his problem. If it is tunicate palsy, the sensory motor deficit, sensory may be intact, pure motor deficit may be there, or both may be there, will be below the level of the tunicate. If it is related to your brachial block, you will have to see, is there any sensory deficit in the upper portion over the deltoid region? Is the deltoid paralyzed? Is any other component of the brachial plexus paralyzed? So clinical neurological examination will give you a clue to the paralysis.
Wonderful, Matthew. Matthew, you are right on the point. So because the clinical examination said that the deltoid is also affected. So if deltoid is affected, that means that it's not the tunicate. However, next slide, please. The subsequent week, the soon after the like the next day, the injection. Hello. So the subsequent week. Hello.
Hello.
Yeah.
Okay, so solumetrol injection was given, and the injection intralipid was also given, considering that it could be related to the analgesic or the drugs which were used. The tourniquet was sent to the manufacturer for checking the calibration, and fortunately there was no problem with that. The EMG, which was carried out at 6 weeks and at 12 weeks, shows that there is a plexus, brachial plexus insult in the axillary area. The neurologist opinion was consulted, and he said that nothing more can be added to the treatment which is already running. The patient was given passive physiotherapy along with the electrical stimulation. Next. At 4 months, the fracture united. However, there was no improvement in the motor or the sensory part. Next. So recovery gradually started after 4 months. Initially, it started with fingers, and then over a period of next 2 months, there was a full recovery. So fortunately, patient improved completely. Then when we try to find out the literature, around 15 cases have been reported with such complication. And in some patients, the deficit has persisted for more than 1 year. So the possibility is like this could be a rare complication of local anesthetic on a nerve, and which has resulted into a neuropathy or the neural damage. And that is possibly is one of the possibility. We cannot prove it like what is the actual cause. So this is a hypothesis. Amin sir, would you like to say something on over and about this?
No, I think you have said everything that we, from the beginning. If I can say something, our anesthetists many times when the surgery is going to be prolonged, adds dexamethasone along with the local anesthetic agents to prolong the effect of regional anesthesia. In those cases, sometimes the effect of brachial lock persists for about 24 hours. So in all these such type of cases, we ask the patient to be aware that this may last for 24 hours and you should not be worried. Another disadvantage of this type of anesthesia is that the surgery where you expect compartment compression syndrome. Not having any sound. Hello.
Yeah, yeah.
Yes, sir, we can't hear you well.
But
hello.
It's breaking.
Yes,
Yeah.
you go on, sir. Whatever
Carry
we
on,
can
sir.
hear, we'll hear you. Okay, go on.
Yes. Okay. So many times when these effect of anesthesia persists for a long time, the cases where there is possibility of compartment compression syndrome that can be masked. That is one disadvantage. And secondly, many times patient becomes apprehensive after 6 or 8 hours. Even if the fingers don't start moving, they become apprehensive. But in this case, we were sure that because it is going to be a small surgery, no Dexona was given. So we were worried from very beginning because it did not anesthetic effect did not take off after 3-4 hours. On clinical examination, what we found that the deltoid was also paralyzed. In a case of tourniquet palsy, deltoid will never get paralyzed because the paralysis is going to be below the level of the tourniquet. So from clinical examination, we were sure that this was some form of brachial plexopathy, which subsequently was proved with EMG and CV, and then gradually the patient recovered. But this was a very unexpected and very painful complication for the patient and for the surgeon both.
Hello.
Yes, Praveen, can you now take over further?
Can I have an input in this case?
Yeah,
Yeah,
sure,
of course.
please.
Yeah. The problem with the needle going not around the sheath or in sheath, but it goes into the perineum many times, and suddenly the patient feels the sudden jerk, and that may create a pressure of that local anesthetic inside. That is the one cause probably. And the second is nowadays we have availability of now locator, and with the now locator, this can be reduced. This complication can be reduced.
Absolutely.
But we had to use now locator in this case.
Okay.
The other thing that can be potentially used is the ultrasound guided block as well, because I think that's been increasingly used just to increase the
Yes.
safety aspect of it.
Yes, they say that in ultrasound guide compared to the stimulator guided block, ultrasound guided blocks have less chances of vascular and neural damage.
Yes.
They use both combined, ultrasound and now stimulated, both combined they can use.
Yeah.
But nowadays the problem is that the ultrasound you can have in your bigger institutes, whereas the anesthetists who were having their ultrasound machine, because of the PNDT Act, they have been asked to deposit the machine at one place, so they cannot take it as a portable machine.
Yes, and it's a shame because the PNDT Act, I really can't understand some aspects, but that's quite a disadvantage for the anesthetists.
Yes, Praveen.
Right.
Yeah, please.
Thank you, Amin sir, for that interesting case. And I'm just coming to the summary of the whole session. And all things considered, we've looked at various aspects of the areas where the clinical errors can happen, right from the examination to medication errors to surgical errors to potentially anesthetic problems. So throughout all this, I think, as I said earlier, the buck stopped with us. And because the buck stops with us, communication is the key. How we communicate to the patient, not just before the event, it's the journey of the perioperative journey. How we communicate, how we build up the rapport with the patient is quite important. So what are our responses? How can we respond? Something has gone wrong. So one response is you try and hide the error and just pretend that this thing did not happen. The other response is to blame others. So find some excuse, blame the assistant, theater nurse, anesthetist, or whoever else, but not me. Or the third option is, which is probably the most difficult of the three, is to openly discuss what's happened with something wrong that has happened. It may be too early. We may not have the answers. So, in 24 hours time, if an adverse event happens, we may not always have the answers, but at least to be able to have an open conversation with the patient is one good approach. But what are the obstacles to doing that? Is the society and the system. Do we have a system in place which would protect the doctors or the institute if something goes wrong? So I would like to ask the panel, what strategy is the best? What strategy would you use, Dr. Matthew?
Yeah, I mean, I have a long answer to that whole thing. So before me, if somebody wants to answer, they can do that. Then I can.
Okay, I'll come back to you. Then I'll ask Dr. Rao first. Dr. Rao?
Yeah, I would prefer to make the answer short because Dr. Matthew is going to explain it in detail. I would prefer the last one. That is, you have to be honest. You own up to the patient, and having developed the rapport and communication of the patient and patient attendants especially, you first tell them the truth, and this has happened, and see how they react, and try and convince them, and see that you can sort it out. That is the best option compared to all other options, according to me.
Thank you. Can I ask Amin Sahib, we've just discussed your case. How did you go about discussing this complication with the patient, sir?
So, frankly speaking, this was handled by Dr. Pandit Sahib, but the first thing was that the patient was taken into full consideration, and he was kept in
Breaking up a lot.
Everyone?
No, it's cutting. Your voice
It's breaking off, sir.
is breaking, very much breaking. Okay. Move
Then
to
I
other
think
opinion, then we'll
I'll
take
come
his
again when
opinion again.
somebody let somebody.
I mean, sir,
Okay.
you can write
Yes.
down your opinion and send to me. I will just read out. That is the one option.
Okay.
In WhatsApp,
Okay, right,
send me in
okay.
the WhatsApp your response,
Now-
or you record on the WhatsApp, and I will show here what we are telling.
Dr.
Okay,
Mani,
okay.
can I have your thoughts while we are waiting? Can I have your input, please?
Lalit ji. Hello?
Yeah, we can hear you.
No. Dr. Lalit is not speaking. It is me speaking.
Okay, sorry.
Where is the Dr. Lalit?
His mic is.
It's on mute.
He's in mute.
Oh, I'm audible now.
Yeah.
So everybody knows that it's a very, very difficult scenario whenever it happens. And I think there would be gradations of the mistake which has happened, and there would be the experience of the surgeon with whom it has happened. Is it a first year resident, or is it a professor who is 30 years into practice? And whatever you say, these things change with time. Definitely the third one is the most, the correct path to be taken, but it needs a lot of courage and experience to get onto that path. It might be a very, very challenging thing for a new trainee or a resident to take that path. And he tends to do the other two, which we have suggested, of sort of hide it or maybe blame it. So those are my thoughts.
Thank you. Right, I'll come back to you, Dr. Matthew.
Yeah. Thank you so much. Three things. I agree with the panel on this fact that you should be honest with your patient. Remember, if there is a problem that you have seen and there is an unexpected, unanticipated complication, you should be the first one to tell the patient. It is far better that you tell the patient than the patient hear it from someone else. Then it is terrible. The patient would think that you hidden from him, is you are dishonest with the patient. The most important thing is please be on the side of the patient, get the trust of the patient that you have been honest with him. There is a problem, this was unexpected, it has happened, and these are the solutions. We will overcome it. Be honest with him and be the first one to tell. That's number one. Number two, if there is a problem that you have seen and you're not the surgeon, remember, do not underrun your colleague's surgeon. I do not recommend. You have no idea what were the situations in which he's operated. Without knowing, please don't be judgmental. So don't be judgmental on your brethren surgeon. It is an important message for juniors. Don't underrun and don't undermine a colleague surgeon without knowing the full ground realities of what happened. Once you've known, you can take a judgmental position, maybe in a committee or whatever. But before that, don't be judgmental. Say, okay, this is a known complication. It can happen. This is how we'll go about correcting it. That's the second message that I want to give. Be very clear on that. And thirdly, once you've told the patient, please give alternative solutions so that he has hope. Don't take away hope from him. So 3 messages that I want to give to my younger colleagues: be honest, be honest and be the first one to communicate the complications. And secondly, if you have seen a complication from another surgeon, do not undermine the other surgeon that has done the procedure. Lastly, give hope by giving alternative solutions to the patient. 3 strategies.
Thank you. And I think that's very useful messages for anyone listening in. And that's a very useful strategy to adopt. But one thing that I would suggest is, in addition to everything that Dr. Varghese has said, is prior to doing all this, hopefully throughout the course of this webinar, you would have seen the importance of building a system. So having a set system that you're working to gives you the courage and the confidence to face any complications that come across. So obviously a lot of this creates a lot of turmoil in your mind. So these are the strategies of how you confront the patient, but how you comfort yourself. And I think I'll ask Dr. Subir Javeri again. Already you've described your mindset when you had that particular complication, but how did you cope with it? What did you tell yourself?
It's very difficult to, kind of tell. You are also hoping that the patient will recover. So there is that element of hope. But over time, when you find out that he is not improving, there is that element of despair. There is that element that, and you have to take comfort in the very fact that you can only do good for maybe 85 or 90% of your cases. 5 to 10% of your cases are not going to improve, and maybe 5 to 10% of your cases are going to have some trouble. There is no way you can be perfect. Nobody is perfect, despite our best of trainings, best of always doing it in good faith. There will be some complications, something is going to happen, and the best way is to discuss that upfront with the patient. Be honest, be very forthcoming, and tell them that I tried my best, but unfortunately this has happened. The solace lies in your honesty. I think that if you have been honest enough with the patient, and there's something that you could have avoided, probably you will learn from it and not allow it to happen in some other case. But that's where the solace lies. So I think honesty and trying to make whatever changes you can in your practice is how one can cope with this kind of a problem.
Thank you. Thank you. Ketan bhai, would you like to add something? I'll come to you in a second, Dr. Singhi.
Yeah, I think I'll just echo the thoughts of Dr. Zaveri, because I feel that every doctor worth his salt will definitely try to do the best under the given circumstances. And yet medicine and orthopedics being a very unpredictable and a very incomplete kind of science, mistakes and those never events can happen. And we need to be, I would use rather the word integrity and sincerity, because integrity is something which I always associate with a person like, say, Yudhishthir, who under the given circumstances always told the truth. But then, because this is, as I told you, quite unpredictable, and sometimes you can get away with unexpected recoveries as well. Wiser, safer, saner to just be on the safer side, tell what has actually happened, and leave a little bit of your destiny to God, nature, whatever, but do whatever best you can in your hands under the given moment. I think that's the bottom line.
That's a good message. Thank you.
I think the most important thing is to be with the patient throughout the course of the entire problem. Do not ditch them. Do not ditch them. Be very sympathetic with them. At times, if they are elderly patients, I hold their hands. I put a comforting hand on the shoulder of that patient and try and make them feel that I am equally disturbed as they are.
Yes.
That conveys our sincerity to them in their minutes of despair.
Absolutely. Absolutely. Yeah, Dr. Singhi, you wanted to.
I think so. Most of the points have been covered. So my just a couple of points I would like to make is, it's always better we have an informed consent with all the known complications which we come across in the literature. So even the remote complication, though we need not explain that to the patient, but at least the patient will try to go through when he signs the consent. So he is aware that these are certain complications which can happen. And the other thing is, once if this complication has happened to us, it is better that we go a thorough research of this literature and see that how these complications have behaved, and try to make, even if the patient goes medical legally, so you can show these studies like these are the literature, these are the complications, so that as Varghese sir has already shown that you have to have it on the paper.
Yeah.
So that is very important that you note these complications in an informed consent, and suppose if this has happened, do a thorough literature search so that you can provide show it in the court if you are in such kind of situation. And one more thing is, nowadays, like mob attacks are very common. So in this situation, we have to be very careful how we deal with the situation at that end. I think so. We have
That is
to,
a very
yeah.
that is a very uh, let's see what Dr. Rao has to say.
Yeah.
Sir, I am fully impressed with Dr. Matthew Varghese and his observation. Only one thing I want to add on to that is, whenever a complication happens, one is handling the patient with love, affection, empathy. But when the complication happens, don't live on pride and ego. Talk to your colleagues, talk to your seniors, get the best, and do not do the same complication again. Do not stand on ego. Call a person better than you, even though it's from the same city. Call them, take their advice, and make them join you for the next procedure. So this is always
Amitabh Bachchan's line, call a friend.
Yes, yes.
Call a friend. Call a friend. Lifeline, lifeline.
But if that person
lifeline.
is better, if that person is better than you, and even if he's your enemy, please call him and see that he helps you.
You have to be humble for that.
There are two questions that come from the Dr. Jawar B. Jetwa. One about the previous case. What about the regular calibration of pneumatic tourniquet? We are not doing any calibration of regularly pneumatic tourniquets. That is the suggestion he has given. Hello.
Yeah. Yeah.
And the second thing he has asked all the panelists, have you come across neural damage during removal of epidural catheter due to acute hematoma that has been documented so much?
Shall I answer this question?
Yeah.
Yeah, this I have seen one of my friend, he has operated a patient for total knee replacement, and for the post-operative pain relief, the catheter was inserted, epidural catheter was inserted. The catheter was removed on the third day when the patient was comfortable, and it was removed. Soon after the catheter removal, patient started developing weakness in the lower extremity. And in a matter of few hours, the patient became completely paraplegic. So it was a Sunday, but still they insisted to get the MRI because it's an acute onset progressive neurological deficit. So the patient underwent MRI and it showed a hematoma at the site from where the catheter was removed. Now the problem was the patient was on anticoagulant.
Yeah.
And that has probably resulted into this complication. So this is a very tricky situation, but what Dr. Jawar Bhai said, yes, this complication is known.
Okay.
Okay.
Navin
Bhai.
Yes.
Sorry, you had also mentioned another question about
calibration of tourniquet.
No, not you said there was some question we are going to take up later on to ask Dr. Mani.
Can I comment on the calibration?
Yeah, please.
Oh, that was on total knee replacement after spinal anesthesia, sciatic nerve palsy, even total knee replacement. It was not a hip replacement.
Oh, it was total
Dr.
knee.
Tejas Gandhi had asked from Ahmedabad.
So we'll discuss that as well. Let's just finish this one.
Okay.
Yeah.
Sorry, Dr. Varghese.
Calibration part. If your institution is an ISO certified institution or an NABH certified institution, there is a protocol that when the auditors come to check your institution, you have to show them These are the instruments which have measuring aneroid or whatever other pressure measurement requirements are there for these instruments. These have been calibrated. The date of calibration has to be mentioned on that piece of instrument. So if you have a protocol of ISO certification or an NABA certification, the biomedical engineering department has the responsibility to audit, calibrate, and put the dates of calibration on that piece of equipment.
Okay, thank you very much. That's useful information. I think we're actually out of time. Do we have time to discuss that query from Dr. Tejas Gandhi, Navin bhai?
Yes, time is not an issue with me or delegates. It may be issue with the faculties.
The panel.
If the faculties are okay, you can go ahead.
Can I put that question to Dr. Mani, please? So if you can repeat the question, please, Navin bhai.
The question is post-spinal TKR was done and there was a sciatic nerve palsy. How to diagnose and how to conclude and how to treatment that case? It was TKR.
I don't think it's a very, very common occurrence. And diagnose of, obviously you'll go by your clinical evaluation, you'll get to know. The more often which occurs is a CPN palsy, which might occur in a valgus knee or in a tunicate pressure related issue, or if femoral nerve injuries, when you give femoral nerve blocks for pain relief. But then sciatic nerve, I'm not sure. I have not faced such a scenario.
He's saying about sciatic now. That's why I'm also worried. It's a sciatic now. We have to localize the lesion where the lesion is. Then and then we can come to know the reason.
Yeah, I think EMG is quite important.
Localization is required. First is the localization. Then comes the reason.
Okay. Okay. Thank you very much. So yeah, so we've come to the end of our session today, and I'll just summarize the take-home message for the delegates. So adverse events are quite common, although it does not get discussed as much in our country especially. But adverse events are quite common, and they have far-reaching effects for both not only the patient but also for the doctors, sometimes for the surgeons, because as we've discussed, it leads to a lot of mental turmoil. So each event should be analyzed. I think what we need to take away from this is just do not brush anything under the carpet. Each event should be analyzed, and this should be used to improve the systems, to improve your practice, because many of these complications are preventable. So as long as we keep on documenting them to improve the system, we will never be able to eliminate complications altogether, but we will be able to reduce the frequency. And hopefully during the course of this session, you would have seen many examples of how and when things can go wrong. And at least these many events will not be replicated in your practice in the future. So I thank you all for being a part of this session. Dr. Verghese, or you have some closing remarks for us?
Yeah, no, just a little story.
Yeah.
Atul Gawande was a resident doctor in Harvard Medical School. While he was training there as a trainee, he faced certain complications as he saw, and he documented it in a diary. At the end of his residency, and when he became an established surgeon, he was a good writer. He wrote a book by the name of Complications by Atul Gawande, and that became a bestseller. When he realized that, he approached the WHO. Look, there are these complications happening globally. There has to be a mechanism for preventing it, and he drew the parallels from the airline industry. Before a flight takes off, every time the pilot has to go through a checklist, and even if one point in that checklist is not ticked off and resolved, the pilot cannot take off. This was because in the pre-1930s era, there were far too many crashes happening. To prevent that, the only way they realized was to have a checklist, check this, and all well fly. Similarly, Dr. Atul Gawande thought of this whole concept.
Yes.
So he was exploring to do this project with WHO. And the WHO said, go ahead. I interacted with Dr. Atul Gawande. He came to my institution and he gave a lecture on safe surgery and complications of surgery. So my institution was one of the institutions which was, there were 8 centers globally that was chosen to do this research protocol, trying to see if having a checklist like the one which is finally evolved, which I showed to all of you, this is freely downloadable on the net. This was used in all the 8 institutions. And when we looked at the final complication rates, and we found that the complication rates fell by 36%. That's a huge percentage in these 8 centers. This is a published paper, the New England Journal of Medicine, downloadable freely. It is published January 29, 2009, volume 360, page 491 to 499. Freely downloadable, and you can look at this as a paper which has Atul Gawande, and my institution is also there. My surgery department was part of this. Is a surgical checklist, and we use this routinely in our department. And we have this surgical checklist, WHO safe surgical checklist, as part of every case sheet that goes to the theater. This is part of our checklist that we have. And the nurse, the doctor, the anesthesiologist, we all have to fill this. So that is Dr. Atul Gawande. He went on to write another book by the name of the Checklist Manifesto. He wrote a third book by the name of Better. And the last book that he wrote is Being Mortal. It's a lovely book on aging and problems of aging and how they have difficulties. When he's taken the first, it's autobiographical, how his parents were aging and he went through their aging process in a difficult manner. So Being Mortal is the last of the 4 books that he's written, and he is a regular contributor to the New Yorker, which is a literary magazine which comes from New York. I was part of a project where the trauma care checklist was evolved. It hasn't become as popular as a surgical checklist. This is basically to prevent missed injuries in trauma patients. And this is a 1-page checklist that is evolved. And this is also freely downloadable from the WHO website, Trauma Care Checklist. It's a very simple protocol. Before the patient leaves the casualty and after the primary and secondary surveys are done, there is one event. And the second is before the team leaves the patient, what are the things that you check for? Very simple, very doable. And in every patient they found it makes a difference. This is also a published paper in the World Journal of Surgery, implementation of World Health Organization Trauma Care Checklist Program in 11 centers across the world. So these are the protocols that we have, and we have the checklist which has three phases. One is before induction of anesthesia, before skin incision, and after the patient has left the operating room. 3 phases, the checklist has to be filled.
Yeah, can I just, yeah, I think it's very important to follow these checklists in letter and spirit. And I think that's the important keywords, because what I've found and I've seen in many places is the checklist being brought to the surgeon after the end of the procedure. Sir, you need to sign here. So I would strongly,
it doesn't work.
That's missing the whole point. Then it becomes a tick box exercise, and it doesn't serve any purpose. So the delegates watching this program, the checklist, if you are following the checklist, please follow this in letter and spirit and understand the idea behind the checklist. So actually me and Dhiren Bhai have devised a full day module, because this is not just about clinical incidents. There is a whole psychology, as Atul Gawande has mentioned in his book as well. There is psychology that goes into these clinical errors, and what are the psychological aspects, how we can prevent them. So we've devised a whole day module, and we run training for corporate hospitals. So if anybody is interested, we'll be more than happy to help out with the training. And if you have any incidents that you would like to share, please email us on the email ID shown on the screen here. So on behalf of Gujarat Medical Association and Dhiren Bhai, I'm very grateful to all the panelists who've contributed their time and experience in making this session a great learning experience for all of us and for all our viewers as well. Over to Navin Bhai again. Thank you.
Thank you.
Thank you,
So I'll
everybody.
stop
Thank
sharing.
you.
Okay. So it was a great experience, Dr. Matthew Varghese. You had a great input, and everybody has given a great input. We are very much thankful on behalf of the Gujarat Orthopedic Association, and it is well moderated by Praveen Bhai and Dr. our own Dhiren. He has already moderated previously 5 POSI webinars fantastically. So we are very much thankful to all the contributors, and we are thankful to the viewers. And let me inform you that it has started with 1822 and highest was 3126 viewers hits on our website. So that is a good number because parallel so many webinars are going on, and subject was such that they were not finding what we are going to discuss it.
Yeah.
Probably that there was missing any pictures or something like that. Some of the comments are that what we are going to discuss, what is the safety of the surgeon. Then I some of the WhatsApp message I replied, come on 1st May, we'll discuss safety and the surgeon both with the COVID. 1st May again you will see the how the safety of the surgeon can be discussed. So some of the people could not understand what is the subject. That was one of the lacunae to make them understand what is the subject, because they were thinking nothing clinical is there here.
Yeah.
Some of the messages were sounding like that. I'm not telling exactly what text is,
Yeah.
but recordings are available, so they will come to know what was recorded here.
So
Thank you very much. So I am just streaming. I'm stopping, and then we can have a 1 or 2 minute